Welcome to AHLA's annual Top 10 series, where we discuss the major health law trends and developments of 2026. Learn more about AHLA at americanhealthlaw.org.
Welcome back, everybody, to the latest episode of the American Health Law Association Speaking of Health Law podcast. I'm Kathy Rowe with Health Law Consultancy in Chicago. Health Law Consultancy is a boutique health law firm that I co-founded over 15 years ago. We focus our practice on regulatory counseling and contracting related to healthcare payment and operations in the managed care space. So in particular, Medicare Advantage, Medicaid, managed care, exchange business, and so forth. I am here today representing the Payers, Plans, and Managed Care Practice Group, of which I am the chair, and I'm joined by Judy Waltz. Judy, do you want to introduce yourself?
Of course. So first I'll note my beautiful background here. My last office in San Francisco, my current one has just as beautiful a view, but I just haven't caught the light quite right yet. And then I'll update my picture. So I'm Judy Waltz. I chair the healthcare practice at Foley, and I am housed in San Francisco. I, in my past, served as chair of AHLA's Regulatory Accreditation and Payment Practice Group, otherwise known as RAP. And just want to encourage everyone who's listening to this podcast to think about getting involved in a practice group, because as long as my involvement has been with AHLA at this point, I found the practice group to be the most fun and the most educational and also the most lasting. We still get together as a group, me as the alum now. And it's just very fun. We refer to each other sometimes as our brain trust. And it's really nice to have people who also focus in kind of esoteric parts of healthcare law that you can call on to discuss various issues. So thank you, Kathy.
You're welcome. And the thanks is echoed back to you, Judy, because the reason we are here today is to talk about your contribution to the 2026 forecast that AHLA published earlier this year in Health Law Connections, a little old school here with the hard copy. And Judy, you focused on Medicare Advantage with the piece called Medicare Advantage in Uncertain Times. So what we want to do in the next few minutes is to share with folks who haven't yet had a chance to read the piece, which I commend to you. We're going to ask a few questions and share some insight from the article. So one thing that you do in the article, Judy, is you set the stage and you talk about Medicare Advantage as a whole and how, since its inception, enrollment in Medicare Advantage has grown. But you also speak to the fact that in recent years, for example, last year, Medicare Advantage organizations began to withdraw some of their plans from the marketplace. And last year, that decrease measured 6% versus, in terms of the MA plan count, versus 2024. So can you speak to why it is that Medicare Advantage organizations are withdrawing plans from the market and what those withdrawals mean for MA members?
So yeah, the numbers are going down a bit. They are still quite high. And more than half of Medicare beneficiaries are in managed care plans now, as opposed to the older days when a bigger proportion were in fee-for-service. But as time has gone on, some Medicare Advantage plans, and it's when I first started doing this work, back when I was a government lawyer, Medicare Advantage had not actually been created yet. There were other variations of managed care plans, and there's a few of those that are still left around. They, from my perspective, aren't making significant contributions, but they are out there, and every now and again you see some twist that applies only to a particular plan. But Medicare Advantage, once it started, and then shortly thereafter, Part D, and often joined at the hip with the Medicare Advantage plan, has grown very quickly, which was the original goal, of course, of Medicare Advantage. The idea that we could control costs and provide better care and be a little more imaginative in how we provide care, all of those designed to address some inadequacies of the fee-for-service side. So all that was good. But some Medicare Advantage plans are realizing now that with certain constraints that have been imposed as the program grew larger, and we're going to talk about one of those constraints in a moment. But as they've grown larger, some plans have realized that the profit that was originally there at the beginning and was hoped for to continue is harder to come by. And so some plans have decided this is not for them. That doesn't, from my experience, hasn't meant they are leaving Medicare Advantage altogether, but that they're honing plans in certain ways and dropping those that are less profitable. It's also important to remember, and this was the point of my article was to sort of put the pieces together, that Medicare Advantage isn't just about the plans, it's about patients and beneficiaries' lives, however you describe them. And it's about the vendors to the Medicare plans, and it's about the government trying to regulate. And so there are many stakeholders in these plans. And one trend that I've been following very closely for one of my clients, but actually more because I was just interested, is that some providers are deciding that they will not accept particular plans now for one reason or another. And surprisingly, for a while I was reading like every single article I could find on this topic. So surprisingly, it's not the biggest complaint and the biggest reason that people refuse to deal with a particular plan or Medicare Advantage organization that provides that plan is not the payment, although that, people aren't happy in many situations about the amount of payment they're getting, but it's usually more things that make them difficult to deal with,
Right.
prior authorization.
Relational issues is what you're
Yeah.
saying.
Yeah, so many, in my case, my client, it was just finding that the payments were so far below what their costs were and everything else that they were done for certain plans, and we're going to tell their patients that they needed to get a better plan if they wanted to continue treatment with them.
So what does it mean though for the MA members in those plans that are being pulled from the market?
Yeah, well, that's a consideration for sure. There are places where plans are limited. So most beneficiaries, and I've forgotten the exact number, but I think it's something like 30. Most beneficiaries um, have a choice of like 30 plans in their area and in their circumstances. But there are some places like rural America where you don't have those many choices, or where it's X county government employees plan or whatever specialized plan it is. So in those cases, there is a problem, and I think that providers, at least the provider I was working with, was considering making exceptions to their usual practice so that they could accommodate and that patients would not be, left out in the cold, so to speak. But it is, yeah, lots of moving pieces in all of this for sure.
Well, another moving piece that ties into the financials of being in the Medicare Advantage space is a piece of litigation that you talked about in your article, Humana versus Becerra, which was which involved a Medicare Advantage organization suing the government and challenging CMS's rule that would allow for the application of extrapolation to CMS's calculation of overpayments based on risk adjustment data validation audits. And the court came down in favor of the plan. So tell us more about this case and tell us how the government is responding.
So the last part is the easiest part. The government has appealed that decision, and cases on appeal move very slowly. In most cases, there have been a few that we've seen for this administration that followed what is called a shadow docket, but we won't get into those. So the underlying issue has to do with how Medicare Advantage plans are paid. And as that system has evolved, and the idea of Medicare Advantage, one core concept is that the Medicare Advantage organization is taking some risk. They're saying they file a bid every year and say, we can provide all the necessary care and the additional services that we can provide, and do it for this amount of money. I'm just flashing back. I handled a FOIA request, an objection at one point, where I was working with my client who had like this huge spreadsheet, which was what had been requested. It was by some professor, I think at Georgetown. He was requesting everybody's. And so we're looking at this spreadsheet with, a million numbers on it. And that's not my skill set, really, reading a spreadsheet. But he
Not
said,
a lot of lawyers' skill sets, so you're not alone.
Yeah, he said, somebody looking at this spreadsheet could tell our whole strategy for the next 5 years. And I wasn't saying, what I said was something like, really? But I think it's actually true. These bids reflect where people are going to move, how they anticipate, providing care with inpatient and outpatient. So anyway, these bids come about. And at one time, Medicare was treating basically all patients the same. You have X beneficiaries and you get X amount of money. So X beneficiaries times Y amount of money. That's an oversimplification, but it didn't work because some patients need a lot more care or a lot more expensive care, or they're in a higher expense area. And so CMS came up with a system where this based primarily on diagnoses. So these are called the RADV. I'm forgetting what the rate adjustment. Kathy, I'm sure you know what is RADV.
Risk adjustment, data validation,
yeah.
RADV.
Yeah.
Everybody just says RADV.
I know everybody
all
says
the
RADV. So anyway, CMS came up with this concept that people who are sicker based on diagnoses that are reported should get more money, and that goes into the bids and and chucks out a number at the end of the day. So what the government thinks happened is that there was an incentive to basically upcode some of the diagnoses codes so that you got a bigger score, a bigger RADV score. So we throw in a few more diagnoses or make them worse. Than some providers upcoded or identified diagnoses that were not supported by the documentation, or for other reasons, these RADV scores were based on data that wasn't reliable. And so the government challenged those and have had some pretty significant settlements. The idea of then how to go back and figure out what the overpayments were presented a real challenge. And so extrapolation is used and has been used for a very long time. In the fee-for-service side, it's in many respects a shortcut. So you look at a sample and then you extrapolate from there, extrapolate against the universe. So you say you've got an error rate of 10%, then you take 10% again, and again, this is an oversimplification, but 10% against the universe and come up with an overpayment. So this was challenged, on many grounds, and that it was not going to produce a reliable number for various reasons, and also that basically these numbers going back years would cause significant financial hardship for the plans because the numbers were going to be huge. CMS had agreed that they would limit how many years they look back. The numbers were still huge. And so the court, in looking at that, found that extrapolation was not an adequate approach to determining these overpayments. The government has appealed. I think they're playing around with some ideas for variations, but right now that is a big, the proverbial 1,000-pound gorilla in the room with respect to plans and what they'll have to pay back for these RADV audits.
Depending upon how things play out relative to whether extrapolation applies or not.
Yeah, and I mean, in my dream world, maybe the government would just say, okay, this is, we're just going to move on, because one thing about plans is that they have a medical loss ratio, and I don't want to get into all the details there, but basically their profit is capped in many respects, and so a huge payback at the end of the day, it punishes the plans, but the plans are the ones who are providing service. So in my dream world, CMS would just say, okay, this is move on, but we'll see if that happens.
All right. So stay tuned on that front. Another area of litigation that you talked about in your piece is about the potential not only for Medicare Advantage organizations as the contracting party with CMS to be subject to false claims action. You also talk about the potential for providers participating in a Medicare Advantage organization's network facing False Claims Act exposure. Tell us more. How can that be?
So,
As
so
a provider saying, "How could that be?
yeah.
I'm
How many times
downstream."
have I heard that?
Right, right.
So it's a strange world we live in. I guess that's the short answer. The False Claims Act is very broad, and it's designed. There has to be a claim to the government. That's about the one of the very few constraints there, and it has to be intentional. But the intentional is the bar basically is anything above a whatever. Just sending something in and saying whatever. So the intention level is pretty minimal in terms of what has to be shown. The real kicker is that there is a recovery for the relators, which is the person who files the case and claims to have. You can probably tell I'm a defense lawyer here. I'm using a lot of words that I'm realizing are more caveated than I used to when I was a government lawyer. Um, the so there's an incentive for people who feel that they've seen something wrong and that it is false and it results in a claim to the government. So in terms of Medicare Advantage, the RADV audits that we just talked about, so we have in some respects a cause and effect, right? The government now is looking at these diagnoses codes and in retrospect is saying, that one was weak, that one was from 40 years ago and nobody's mentioned it since. Why is that in there? And so, and there are arguments to be made as part of their history, increases their risk. And those kinds of issues can be subject to a lot of debate. So along the way, though, if you have a pattern in practice of suddenly everybody has this same diagnosis from 40 years ago, things start to look a little off, and then it starts to look like things were intentional or at least above the whatever standard. And so you have a relator, maybe someone in the coders. Like more recently, it's even been people in the compliance departments who see something and then file a False Claims Act case. And then most of these are settled. I would say, and I don't have the exact percentages, but probably at least 95% of these are settled because it's so expensive to litigate, and litigation is always such an unknown in terms of results. So the cases settle. We don't have court precedent, but we certainly see the dollar amounts, and everybody's worried about the risk. So we have those on the plan side. The plan saying, I don't think I did anything wrong, but just this is what I usually hear, just get me out of this and do it like by next month before I have to do some sort of accounting statement. So that's where the plans come in. The
Right.
plans receive the money. And typically in these False Claims Act cases, that's what you're looking at. How did the money flow? Money started with government, the government paid whom? And that would be the plan here. But the government has also been looking at providers who actually do the coding. So the RADV system is based on diagnoses codes. Those come from the doctors. And so there starts to be a suspicion, like, why did the doctors do this? And didn't that enable the plan then to charge more? And then what was the benefit to the provider then?
Right.
Is there a kickback there? And
Right.
kickbacks can lead to False Claims Act statements. So there haven't been as many cases against providers, meaning physicians, as there have been against plans, but it certainly is a risk, and it's something that needs. I'm sure we're going to see more of this. I'm not
Yeah.
saying that providers or physicians don't code appropriately, but it's just an additional risk that they may not have thought of.
Well, it seems like with the fraud focus of the current administration, it's an area to which providers ought give attention if they are
For sure.
contracting in the MA space.
Yeah, for sure.
Okay, final question. Your article was entitled, if memory serves me correctly, MA in Uncertain Times. So, do these uncertain times portend changes to Medicare Advantage as we've known it? And if so, what changes might be, emphasis on might be, on the horizon?
Yeah, that's a really tough question. So first of all, I feel like the last year I haven't been able to predict anything. And I've been surprised on it almost every day by something that's happened. So where where things will go is an open question. Our health system, though, is facing a real crisis on several fronts, including uh, just making sure that, from a public health perspective, that people who are sick get treatment that they need and don't make the rest of us sick and things of that sort. So Medicare Advantage, as originally conceived, was designed to provide for more traditional or less traditional, more innovative approaches to healthcare, which right now it seems like the timing is perfect, but the infrastructure for MA is big and clunky. And so it's hard to move quickly. But I think we will see particularly with more stress on the plans, we may be getting more creative ideas from the plans as opposed to from the government. And hopefully, and I think this administration is pretty committed to more imaginative provision of healthcare. So I think there's real opportunity for the plans to come up with some really good ideas and see how they play out.
So it's kind of like the pandemic era where external pressures may
Mhm.
force movement and evolution that might otherwise have taken longer to get here.
Yeah, Kathy, I'd be interested in your thoughts on that too, where things will head.
I too am not comfortable making a prediction. I just look across our healthcare system and it seems like there's just so much stress relative to the financing of it, not unique to Medicare Advantage. We're spending 5 trillion or so as a nation, and there's just not the feeling that we're getting the care results, and we're running out of places to turn to afford that financing. Everyday Americans don't have the ability to absorb where premiums are going or deductibles are going, and the government is facing challenges relative to its own financial posture as well. So I do go back to what I said, that it seems like it's a time that is ripe for innovation, that we've got an administration, particularly with respect to tech structured innovations, are open and receptive to it. It'll be interesting to see what some of the public comments have been relative to the federal government's recent requests for information about ways to apply AI in the healthcare space.
Yeah, it's a hot topic.
Yes, yes. Well, AI and tech
I
generally,
know.
but the focus certainly seems to be on the potential of AI to bring greater efficiency and effectiveness to our healthcare system. But bottom line, I think it's an environment that creates the opening for you to probably come back next year and write a forecast for 2027.
Maybe. At least I think we'll see where that RADV litigation goes. I think that's going to be very, very interesting and give us a lot of insights about more than that particular legal issue. So we'll see.
All right. Well, with those closing remarks, I thank everybody for tuning in for this episode of AHLA Speaking with Health Law. And if you haven't had a chance yet to check out the top 10 for 2026 to which Judy contributed, please track that down online or in your mailbox and take a read.
Thank you, Kathy.